Is my screen shared now?
Yes.
Okay, fine. Just 1 minute to go. Okay, good evening, everybody, and welcome to another session on surgical academia. I think surgical academia is now well known to both the speakers, Prof.Joel Leroy from France and Prof.Armando Melani from Brazil. Both of them are acquainted with the platform. Only for those who have joined new, our friends from the international circuit, those who have joined new, for them it's just a teaching and learning platform which was born in the year 2012 in SCB Medical College when I think it's not. Yeah, in 2012 when the laparoscopy surgery training center was inaugurated in that SCB, that time it was born. Then gradually it became a teaching and learning platform for surgeons across the country, surgeons from many parts of the SAARC countries. Classes, live hands-on workshop, hands-on training, live workshops. These are all regular features. So gradually requests from other parts of the world also started coming in to join this platform to get trained. And I was lucky to be supported by many of my colleagues, both the senior and junior. So it was an enjoyable platform with teaching, learning, and training. And in the meantime, 2018, I switched over to AIIMS Bhubaneswar. There also we started the Advanced Laparoscopy Surgery Training Center in AIIMS Bhubaneswar, and we started for the first time in Eastern Zone of the country a postdoctoral fellowship course in minimal access surgery. Then the pandemic came in March, so thereon we started initially as a solo venture, weekly webinar. Then I started chipping in my colleagues from across the country and many parts of the world. Now it's a Facebook page of 808 members from 15 to 17 countries. So it's a educational platform which is moving on well. Today's speaker is Professor Joel Leroy from France, who is the founder chairman of the Hanoi High Tech and Digestive Center in St. Paul Hospital in Vietnam. He is a pioneer, he is an educator, he is a surgical teacher, he is an inventor, he is a master educator in laparoscopic colorectal surgery. Professor Leroy is well known in the field of surgical laparoscopic colorectal surgery across the globe. He is a visiting professor to Osaka Medical College in Japan, in IRCAD, in AITS in Taiwan, in Guangzhou Hospital in China. And the most prominent thing is more than a quarter of a century, he has been a leading figure in the field of minimal invasive surgery, not only as a trainer for thousands of surgeons, fellows and residents in the hospital and in educational courses, but also as an innovator, designing new medical devices and instruments and newer surgical concepts and best practices. In 2013, he received the Pioneer Award in Minimal Invasive Surgery from SEGES. He is probably the only non-American to receive this award. And now he is focusing more on this Hanoi High Tech Digestive Center in St. Paul Hospital. I had the privilege of getting acquainted to Professor Leroy in 2013 when I was presenting in SEGES and he was in the front row. Then we got introduced to each other, and from probably after that, we have not looked back. It's a friendship of only 7 years, but it has gone stronger day by day. Thank you, Professor Leroy, for accepting my request to come on this platform and willing to present the adequate lymphadenectomy in total mesorectal excision. And he is with his best people. Professor Armando Melani is a very good friend from Brazil. He is a professor of surgery in Federal University of Brazil and the scientific director of IRCAD Latin America. Armando is very vibrant and active in colorectal laparoscopy colorectal surgery. He's a colorectal as well as a transanal surgeon at America's Medical City in Sao Paulo. He is since July 2011. He is the director of IRCAD Latin America. That was when the IRCAD Latin America was inaugurated in 2011 in 9th of July. So thank you very much, Armando, for accepting my request to come in today and deliberate on total mesorectal excision. Probably that's one of the very interesting topic to be with. And next week, same time, we'll be having a discussion on carcinoma gallbladder, where Professor Vinay Kapoor from SGPGA Lucknow will be the moderator, and he'll give an overview of carcinoma gallbladder. Professor Anil Agarwal from GB Pant Hospital, New Delhi, will be talking on how to perform an open radical cholecystectomy, and I'll be highlighting on how to perform a laparoscopic radical cholecystectomy. That's next week, same time. So you are all welcome for the same session next week, 8 p.m. India time. So without wasting much time, may I now request Professor Armando Melani to first talk on total mesorectal excision, and after that, Professor Leroy to take up with what is the adequate lymphadenectomy in a total mesorectal excision. Yes, Armando, please. The screen and air is yours.
Thank you very much, Manash, Professor Sahu. It's a great privilege being here with good friends. I can see Joel, my master. I can see Frederic, that I miss a long time. And
welcome, Frederic.
It's always nice to be among friends and to share a little bit about the concept of TME. And so I want to share or try to share a little bit our ideas behind of this surgery, but just to remember that we were not teach to proceed in this way. Apologize by my cough and interruption. I'm just recovering from COVID. But in the past, if you see the book that was gave to me for I learned how to do rectal surgery, and when I was in my residence was Gollinger. And if you can see the picture in your right side, they used to use the finger to dissect the rectum, and that was the way to dissect the rectum, using your own hands, and no sharp dissection, as was told by Bill Hild, and all the package that is related to remove all the mesorectum. And I believe that Joel is going to explain about the package and the lymphadenectomy later. The most important thing is that besides, it looks like an easy technique if you try to do it by laparoscopy. And the team of Joel in France, they proved that this is not so easy, because you have to understand a lot of different maneuvers to expose the rectum in a proper way to keep the package intact and have a very good circumferential margin in the mesorectum. And more than that, if we go to the literature in the last 30 years, we discover that there is enormous variation in terms of conversion for this type of the procedure. In the hands of Korean, the conversion rate is 1.2 or less than 1%. In Europe, in the classic trial, the conversion rate was 34%. In US, in Lujan, hands is 17%. What does it mean? It means that depending on the experience of the surgeon, depending on which kind of patient he is stressing for this type of the procedure, you can have more or less conversion rates. And conversion rate is related in majority of the case to the difficulty of the case, that is If you try to put this in a score, in a what means difficult cases, means obesity, BMI over 30, means very low tumor. It means rectal tumor located in the distal third of the rectum. And it means sometimes that patient can receive previous chemoradiation therapy. And it means also patients male, where the pelvis can be a little bit narrow if they are obese, and it's very difficult to maneuver the rectum to dissect or have the good view to perform a good TME without damaging the package and avoiding conversion rate. And we, as surgeons, we agree in the order to perform the TME probably in nowadays in 100% of the time. The majority of surgeons, they do in the same way. The majority of surgeons for very low anastomosis, they do the splenic mobilization as one of the steps for a non-tension and a very good anastomosis. But usually we start our procedure doing the posterior plane, anterior plane, lateral dissection that we alternate left and right, and then we go deep in the pelvis. I want to share a little bit the video where we understand that TME starts. And we understand that TME starts at the when you sorry, when you ligate the artery. And so we start our procedure at the trying to identify the origin of the artery. We isolate the artery, and we really believe that the TME starts here because as Joel is going to explain, we have to remove all the package of the lymph nodes that surround the artery. And so we like to clean the artery, as I'm doing now. And this video is speed up, it's not cut. And so we have some minutes that I'm gonna show my technique. We ligate the artery. We can use energy device for that, or we can use clip, it doesn't matter. But the most important thing is that once you get the proper plane from the artery, we love to use monopolar, because monopolar is the tool that is going to allow you to be in the proper plane. Once you do traction and counter traction, monopolar and pneumodissection is going to help you to identify the proper plane. And so you can see that when you apply traction and you wait a little bit, the pneumodissection, and use a pure cut without coagulation, and we like to use a power of 25 watts, we are able alternate, we switching from coag and cut mode to dissect in a proper way. We use cut because we are going to have less energy spread, and we are going to provoke less smoke. Once you can identify the planes, usually we go medial to lateral, as was taught before to us by laparoscopy. That was the best way to perform it when you are applying laparoscopy. So you are able to identify ureter and the gonadal vessels. And also you are able to go at the level of the promontory as you can see. And once we got the posterior part of the promontory, I like to go lateral to detach the lateral attachments of the sigmoid. And for me, this is an important maneuver because once I do that, I'm able to mobilize the rectum laterally or medially as I need to identify the plane that I want to dissect. It's very important to have a camera that follow your eyes. And so I am working with a 30-degree scope, and it is important to change the position of the scope and the camera to have the right position of the camera in the horizon. And as you can see, use energy and we use the traction. We use to dissect with the tip of our instruments, initially at the left side, and then we go to the right side. But we modify our technique a little bit because usually we used to do this very deep posterior dissection, and we don't do this anymore. We don't go deep posterior as we used to do in the past. We try to go surrounding the tissue, trying to keep all the planes in the same level. And so we move, or we decide to change our technique to enter a little bit earlier in the anterior plane. Sometimes, depending on the amount of the fat, you can be in the wrong plane. And this is very important to understand the relationship of these planes. As I told you before, we earlier engage at the anterior dissection. We believe this is very, very important because we understood that if I connect anterior earlier, I can keep my lateral plane in a proper plane. Because usually in the past, if we follow the lateral plane without connecting with the anterior plane, there is a big chance to be very lateral at the left side. And so here, what we are doing, we are connecting the anterior part of the plane, lateral and the right. The camera is a little bit turned to the right side. It looks like we are doing lateral side, but in fact, this is anterior and this is posterior. And you can see the seminal vessels over here. The camera is not at the horizon now. And this is important to show because if your camera, he cannot follow you, you sometimes can be in a wrong plane or can be mistaken by understanding where you are. Now we have one instrument lifting the anterior part of the dissection, and we are applying some traction from the right side to the medial part, and we are dissecting a little bit of posterior and right side. And now we are connecting anterior with lateral right side. And now we are switching to connect anterior with left side. As you can see, we don't go deep posterior as we used to go in the past. we just surround everything, because we understand that if you surround everything and go deep, plane by plane, surrounding as a circumferential dissection, there is less probability for you to get lost. And we don't try to remove the rectum from the pelvis. In fact, we just use a small compression of the rectum towards to the sacrum. In this way, we are able to see all of these attachments, and we are able to keep the proper plane. In fact, we modify this technique because using the robotic tool, we learn a little bit how to deal with this tissue in a different way that we used to deal with laparoscopy. And so what we are doing now, we are combining some exposure techniques that we learn from the robot that we can apply in laparoscopy to have a better view and to have a better understanding of the limits of the mesorectum. We are now going a little bit deep posterior. As you can see, not all the planes are in the same high. And this is probably, for me, the most important thing, because the 2D division usually trap you sometimes, and you choose the wrong plane. When you are in a 3D view, you can choose better your planes. But if you start to surround everything and try to connect the planes at the same time, the entire circumference is going to be more difficult to be trapped by the view. And so, checking our previous videos, we understood that in some maneuvers, usually dissecting at the left side, we usually, in the past, we used to go very deep in the lateral wall because we try to follow the planes, and by the limit of the instruments or by the angulation of the instruments allowed us to go deep in one side and to go superficial at the other side, at the right side, where usually we work parallel because the position of our trokers. And so if we go and see, if you go your dissection, trying to go surrounding and a spiral to the rectum, there is less chance that it happens. And this is what we are doing nowadays when we use laparoscopy to do the TME, to do the rectum dissection. Even if it's obese, or even if it's a male patient, we are able to dissect very deep in the pelvis, as you can see. But for me, the most important thing is to have a very good camera that understands what you have to do, because he is your eyes. And so he's gonna show you what you need to see. And the majority of the place where we are working, we have only one assistant to help us. And so put one more troker is not gonna help, because we have no more hands inside of the OR to help us. And so we have to deal and with what we have. It means that it is what it is. And I have to work only with one camera, and this camera is at the same time is gonna assist me. And so this is why we work with 4 trokers only, and this is what we are doing now. So I just want to share some things that we used to do in the past. Very deep posterior, easy patient, easy dissection. Just just let me do something here. Just good. And so, as I told you, it's an easy patient, easy dissection, but by the angle of my instruments, yeah, you are gonna see that I'm gonna commit a serious mistake. And this is the this is a bleeding of in interior uh, um, in, the internal iliac vessel. Yeah, and so we keep the with compression. We put some compression over here, and then with the compression was again enough to keep it in a proper way. And so we finished the dissection of the mesorectum anterior. As you can see, this was a very easy case, not so busy one. And in those cases that are very easy, where you have very few space to commit mistakes, because 1 centimeter, 1 millimeter deep inside, you can be wrong. And in this case, as you can see, is a very skinny patient, very easy to dissect. We were 1 millimeter deep coming from the right to the left side, and we committed mistake to damage the internal iliac vessels. And this is the monopolar dissection of the same patient. You can see the sponge down deep in the pelvis. And this is one of the reasons why we decided to change our strategy to avoid to go very deep posterior. And we decide to change our way to dissect the rectum, going in a spiral way, surrounding all of the parts of the rectum. So posterior, lateral, left, lateral, right, and then anterior, to avoid this kind of mistakes and understand very well where the plane is. And for this patient, we just put some stitch and we correct our mistake. But anyway, this can be a reason for conversion. And I really believe that to surround the rectum planes is the best way to perform TME nowadays. It's not go as we used in the past, deep posterior, left, right, and then at the end anterior. I really believe that it's important to start left side, right side, connect anteriorly, and then surrounding everything and going deep at the same time, surrounding the rectum as in a spiral, going deep into the pelvis. So this is was I would like to share with you, and I like to thank you for this for letting me share with you these ideas and this way to do the mesorectum. Thank you very much.
Okay, thank you, Armando. That was an excellent demonstration of the tricks of doing a proper TME, and getting into the proper plane is probably more important than anything else. So we'll be taking up questions at the end of Professor Joel's session. So could you now share your screen, Professor Joel Leroy? Armando, you can stop sharing your screen.
I did. I stopped.
Okay, thank you. Thank you. Professor Joel, you have to press present now, then choose the entire screen, then share. Yeah, there it is. Fine.
Joel, we don't have your sound.
You are muted.
Yeah. Sorry.
Yeah.
Yes, I'm happy to see that Frédéric Bretagnol is present, because we did together this presentation, and I want to thank Professor Manash for all the work he's doing from helping us to perform regularly and every week new webinar. So, sorry, it cannot work. I do. Why it's not working, my presentation?
And it's okay. Yeah.
No, but when I click, it's not working.
Is it?
And is it okay now?
Yeah, we are able to see the first slide.
I think I will.
No, the second one is probably hidden. That's why you are not able to see. Go to the third slide. Probably it will be fine.
No, but my slide is not moving.
Is it?
Aha. My slide is not moving.
Yeah, it's okay now. Yes. Yes.
No. So I will change the parameter of. I will choose this. Okay.
Okay.
Normally. It's coming.
Yeah.
So, lymphadenectomy, as I said, Armando, is very important when we do oncologic resection, particularly for rectum and colon. And there is some consensus concerning lymphadenectomy when we do oncologic resection. Why we do that, we have to achieve accurate staging, and for that, surgeons and pathologists together recommend examination of a minimum of 12 lymph nodes removed depending on the segment of bowel with the tumor. Although the evidence base for this is very weak. But in the literature, we know that the number of lymph nodes evaluated after surgical resection was positively associated with the survival of patients with stage 2 and 3 colon and rectal cancer. These results support consideration of the number of lymph nodes evaluated as a measure of the quality of colon cancer care. So To summarize, we have to do in adequate lymphadenectomy removal of 12 nodes, but it is not enough. And we have seen during the very nice demonstration of rectal resection, we have to resect all the rectum, the meso, respecting the propria fascia, and having a lateral margin minimum 1-2 millimeter, particularly for distal rectum, and distal margin 1-2 centimeters. And we have also to do surgery for preserving anal continence, genitourinary and digestive function with a low mortality and morbidity. To remember, where are the nodes? This is a posterior view of the rectum and with vessels running posteriorly. This is a IME division, 2 branches, and with nodes around. We have also some nodes coming or running around the mid-rectal vessels coming from internal hypogastric vessels. And we have to take care, particularly we will see, for the distal rectum, rectal tumors. We have to remove the nodes depending of these vessels, IME, IMV, and particularly to remove the node 253. That is the principal nodes, that is the nodes at the origin of the IME. How we do exactly as Armando just shown, where personally I always begin by artery. He don't spoke of the mobilization of his splenic flexure because I remember he was usually doing a first mobilization. And as you see exactly what he said, we open the retroperitoneal space and using traction, counter traction, we will do a skeletonization of the IME at its origin, removing the nodes, the 253 from the Japanese classification, and we can do a separate analysis. And I know he proposed to use monopolar, but I have seen he used sealing for the dissection of the lymphatic. This is to avoid lymph leak post-operatively and eventual contamination, and I have beautiful video showing that. Then we will divide the IME, so the nodes were removed and we put in a small plastic bag, and we will continue the dissection from medial to lateral, taking care of the plexus we see very well here. This is a particular case. As you see, we have nodes. This is Riolan arch vessels. I kept it. And close to these big vessels, interesting to keep, to have a possibility to take down the descending colon and doing the vascular, doing the anastomosis, keeping part of the sigmoid. We remove the nodes around the vessels, removing en bloc the vascular package, artery and vein. And you see the advantage of keeping the Riolan arch is to have a beautiful vascularization of the proximal sigmoid too. And we will keep this vascularization to do anastomosis, avoiding too large mobilization of the splenic flexure. Then we have seen embryologic anatomy, and Professor Hill explained that we have to respect the propria fascia of the rectum because we have nodes, but we have some nodule in the meso. But it is exceptional, except advanced tumor. In T2, in stage 2, stage 3, to have invasion of the propria fascia. So it is why we have to do the dissection as exactly we have seen with Armando. Laterally, we have space between the propria fascia and the sidewall fascia. And in this space, we have vessels, nerve, lymphatic, crossing. We have seen Armando using monopolar. I did a lot, but I think in oncology, we have to dissect space with monopolar, but we have to divide plexus, vessels, lymphatic crossing by a sealing system. We will do on right, on left, anterior. I continue to do the dissection, as said Armando, beginning posteriorly, not going too deep, as he said, but dissecting around the rectum to slowly dissecting medial to the side wall fascia and anteriorly medial to the posterior to the Denonvilliers fascia in the majority of cases, except for some tumor anterior where, and we have had a webinar on this question, anterior to the Denonvilliers fascia. And we will do the dissection. The goal is to remove en bloc the rectum, the meso, and the fascia surrounding all the structures. Concerning pelvic lateral lymphadenectomy in mid and low rectal cancer, this is more and more used. Lateral lymphadenectomy, I performed this since 30 years because I was doing gynecologic, oncologic pelvic procedures. And it was in uterine cancer, the indication to do systematically. So I was doing by laparoscopy since a long time. And I remember beginning of laparoscopy in rectal surgery, it was also proposed by a team open to do lateral lymphadenectomy. But with good radiochemotherapy, we will see that perhaps indications are not so developed. You see, for the tumor of the 2/3 superior part of the rectum, majority of drainage, lymphatic drainage will be up, except in big tumor, when we will have obstruction of lymphatic and we will have possibility to have a drainage on the hypogastric plexus and lymphatic, as you see for the low third of the rectum. So lymphatic anatomy, lymphatic drainage of the rectum, it's parallel to the arterial supply. We have first intramural lymphatic plexus, beneath the mucous membranes drain into superior, middle, inferior rectal nodes. These perirectal lymph nodes, along with mesenteric lymph nodes, then enter into paracolic and intermediate nodes traveling along the hymen. The drainage ultimately proceeds to the aortic, para-aortic nodes. But it is for advance, and it's not sure that surgery will do a perfect resection of all the nodes if we have this type of evolution. In the upper 2/3 of the rectum, the drainage will be along the hymen. In the lower 2/3, drainage mostly proceed along the superior rectal artery to the hymen. A small amount of lymphatic flow, mainly from below the dentate line, may drain laterally through the internal iliac system to the superficial inguinal lymph nodes. Also, in case of anterior tumor, not close to the meso, and in case of big tumor that can downstage after neoadjuvant radiochemotherapy. How we do? This is a view, how I do. We can do iliac lymphadenectomy. Iliac, you have three parts: external, medial, internal. It is exceptional to do external, but we know that we can have some inguinal nodes positive. Usually it's for distal rectum. And you see, after we have opened the peritoneum, we slowly do the lymphadenectomy, external lymphadenectomy. And I use, in the past, we were using clip. Now I use sealing system for dividing lymphatic and seal the lymphatic. If not, there is a risk of postoperative lymphoray. And some postoperative ascites were described. Particularly, I have seen paper after robotic when they use only monopolar. We have not to use monopolar, we have to seal the lymphatic or to clip. Clipping is longer. Then, as you see, I'm dissecting lateral between muscle and artery to free the lateral attachment of the package of the nodes. We continue slowly using atraumatic blunt dissection, doing traction, countertraction. We see soon, we will see the obturator nerves coming. I'm doing this lateral dissection. As said, he said camera, but he wanted to say cameraman. I suppose it is important to have a good cameraman to follow you. I said this is how we recognize that the cameraman is ready for doing procedures. It is the mind-piloted video navigation when the assistant cameraman is able to follow you. I have kept, as you see, the dissection to be approximately in real time. I have not cut. So this is to see the time. We see the vein. I will do a small error, you will see, but I'm controlling. I always say going slowly to go fast. And we continue the dissection. We are medial now to the, you see, a small branch of, I will divide a small branch. Can be a big problem. Fortunately, it was a branch. I will do advantage of this instrument, a coagulation only. I was close to the iliac vein. I'm doing, as you see, coagulation very close to the wall. And I control. So we have to go slowly. And we continue the dissection. This is obturator nerve. It is what we can see when we do inguinal hernia repair. This is similar, but we dissect more the vessels. In inguinal hernia, we keep, and but we can see like this. And from distal to proximal, we will remove this is the obturator node. We have to remove because it will be, as I said, we do that also in gynecology or in urology. If you want to learn how to do, you ask to urologists, they do routinely in digestive surgery or gynecologists, they are doing that. In digestive surgeons are discovering, and it's coming back now because people are using a robot and they are saying, because we have a robot, we can do that. No, it's done since 30 years by laparoscopy. This is the node. We are removing the main nodes we have to remove. But as you see, we have not to dissect in the nodes, so we will keep it. We'll put in a bag, plastic bag, a small one. We remove all. We have not to remove only the node, because if we do that, we will not have all the package. We have to remove en bloc, and we have not finished. This is not finished. This is the obturator. And we will remove the node at the crossing division of iliac artery between external, internal. At this moment, we are removing the nodes at the division of the external. And I don't know if you see very well the movie, the pictures. So you see, don't cut, seal always. This will be put inside. We can put in separate bag. Then we will do on the other side, on right, when we are finished. You will see on the other side, we will not remove external iliac. This is the umbilical artery. We see the umbilical artery behind the forceps. This is the obturator nerve. And the iliac vein. So you see on right, we have the lymphatic external iliac external group, but we will not divide them. But I love to begin like this, to free laterally, as you will see. We see better because we are on right. It's perhaps easier because we are working on right. You see the technique of dissection, that is mainly traction, counter traction to atraumatic. We see very well the vein. No, it's the muscles. The vein is not at this, it's coming, yes. Now, we free laterally to the vein between the side wall muscles. We will do deeply. We have to free. It's good to have a traumatic instrument. Don't catch too much. Okay, this is the muscles. I have sound with children.
No, it's muted now. No problem.
No, you see the muscles? We do soft dissection, balloon dissection. We go slowly. It's not cut. It's a movie real time. Not all the movie, but the dissection is real time. It's good to see when we divide to see the blade, active blade of the instrument. Then we come back medial to do exactly what you have seen before. We have the umbilical artery. We will have the nerve. This is umbilical artery. And you see, it's important to have a good assistant helping you. The key is to begin distal, dividing the attachment at the level of the femoral arch. And we see that slowly we free. You see, I don't cut, I seal always. Going slowly like this, we continue. We will remove all the lymphatic now. Sealing, distal. This is a lymphatic. The obturator nerve. This is a lymphatic. We have to seal. If not, we will have lymphory. Or you clip. But clip, you change instrument, you lose time. You see, I coagulate first and I cut after. First coagulation, sealing first. Then cutting. So this is a lymphatic package. It's not finished. Okay, first, but we have another package there to be removed. You see at the end, we have a skeletonization of all this is not removed. We have to remove. We will do now. This is a cannula with a section. You see, I don't put the blade in contact with the nerve. It seems long, but it's soon finished. So we will put in bag, plastic bag with valve, so we can push and it's not coming back. So I'm changing. I will not show you this. Oh, adequate lymphadenectomy. Is it the problem is different if we are in West countries or in Asia. In the West countries, lateral nodal involvement may represent systematic disease and preoperative radiochemotherapy that can sterilize. So in West country, the standard therapy for lower rectal cancer is total mesorectal excision with neoadjuvant radiochemotherapy. And lateral pelvic dissection is rarely performed. In the East, it's different. There is a positive attitude in regard to lateral pelvic lymph node dissection. They consider that lateral pelvic lymph node metastasis is as a regional metastasis, and the clinically suspect lateral nodes cannot be removed by neoadjuvant radiochemotherapy. The selective lymph node pelvic dissection after neoadjuvant chemotherapy may be found to be promising treatment for those patients, but they are evaluating. In France, it is in French, recommendation, lateral lymphadenectomy systematic is not recommended due to morbidity and particularly bleeding, genitourinary complication, and not better survival, not better local recurrence when we do a good surgical procedure. And Fujita from the colorectal cancer study group of Japan Clinical Oncology Group did study. It's a multi-center randomized control study with a non-inferiority series and including 700 patients, two half similar population. And what they found concerning morbidity and mortality for their study, we have more blood loss. We have a longer operative time, and TME alone seems non-inferior to TME with lateral lymph node dissection. So, is it necessary? So they have studied different groups. I'm passing rapidly on this. Is it necessary? Conclusion, the data suggest that there is a subgroup with lateral nodes responsive to neoadjuvant radiochemotherapy. Those groups will have no benefit when we do a lateral lymph node dissection. In the subgroup with persistent lateral pelvic node after neoadjuvant radiotherapy, they will have a benefit of lymph nodes, lateral lymph node dissection. Thank you for your attention.
Thank you, Professor Joel. That was, in fact, an eye-opener for all of us, that how to go ahead with lateral pelvic lymphadenectomy in selected group of cases, is it that you perform a lateral lymphadenectomy in rectal cancer, or you choose your cases? Your final data showed that it has high morbidity and it's a longer operating time, and the dissections were all fantastic, but is it required to be done for all mid and low rectal cancers, or how you choose? Because you showed a data that Western people, they're happy with only TME, and in the East, TME with lateral lymph node dissection. So how is your criteria? How you choose patients for a lateral pelvic lymphadenectomy?
The case you have seen is a young male patient, 45 years old. He had
could all of you please not press that present now button? Okay, you please go ahead, Joel. That's absolutely not a problem.
The case you have seen was a young male patient, 45 years old.
Okay.
He had, I will say, T4 anterior mid-rectal tumor with suspicion of positive nodes on left.
Okay.
He had preoperative radiochemotherapy with good downstaging.
Okay.
And when I did the lectures on de novo fascia, I presented the case of a small nodule that was a fibrotic nodule with suspicion of invasion of the de novo fascia and prostate. And I did the removal, but it was negative. But in this case, I conclude it was necessary to have to do lateral lymphadenectomy. In the other case, I don't do. If there is, we respect the protocol that is recommended in France. Not do systematically, because if you have good radiochemotherapy in neoadjuvant, you will have good results. The problem is you cannot have neoadjuvant radiochemotherapy with modern equipment in all the countries. And it's why surgeons, and in Japan, they were not using neoadjuvant radiochemotherapy. It's why they were proposing to do lateral lymph nodes dissection for mid and low rectum, and for advanced cases, not for early cases. And the problem in the morbidity, you have more sexual, more urinary problem. This patient had postoperative urinary retention, and it is exceptional when we do a TME, as Armando have shown, that is, we have no urinary retention postoperatively, except if the patient has adenoma of the prostate, but we remove the urinary catheter, day 1, 2, and we have no urinary retention. And I don't agree with recommendation of Bill Hill that say putting a cysto catheter during 1 week, 2 weeks, I don't remember. This is what we were doing 30 years ago when we were doing APR.
So is it that I will come to a conclusion that if we are suspecting that the neoadjuvant RTCT is not adequate, and you suspect that there are reports present on the lateral wall, then you choose them only for this lateral pelvic lymphadenectomy?
Exactly.
Am I right?
You're right. Yes.
Okay. So I mean, then it's not.
This is my conclusion. The conclusion.
Armando wants to highlight something here on this.
Yes. Well, here in Brazil, we have a more clear discussion on suspicious lateral nodes. And as we do a lot of neoadjuvant treatment, because we understand that we can have a complete response. So we start to study this, and in the last 2 years, we have a lot of papers coming from Japan and even Korea, showing if your node decrease less than 5 millimeters in the minor axis, probably this node can be left behind because the probability of metastasis is very low. But if your node even have a response on chemoradiation therapy, and the size is more than 5 millimeters in a small axis, this should be removed. And so we are removing the nodes in selective way if they have more than 5 millimeters after neoadjuvant treatment. And usually we evaluate these patients 12 to 16 weeks after the treatment of neoadjuvant therapy. And this is very, very important. And I believe this paper was published last year in Lancet Oncology, showing the minimum size to consider as a suspicious node after chemoradiation neoadjuvant treatment. And if you use this as a landmark, you probably are going to select the case that are going to need to be removed. You are not going to touch those that you don't need to remove it. And I believe this is very important because, as Joel said, if you do this systematically, you can have a lot of problems related to the outcomes of the patient. And so we believe that this therapy should be used for selected patients. And these patients that are suspicious, they are going to be benefited by this therapy.
Okay, Armando, is it not a much longer time that you are living following a neoadjuvant treatment of 12 to 16 weeks and then following it up with the lymph node assessment? If it is more than 5 millimeter, then you are recommending for a lateral pelvic lymphadenectomy, and less than 5 millimeter doesn't require a lymphadenectomy. So is that what? Yeah, please.
We are delaying more and more the time for surgery.
Okay.
We
is
used
it
to
your routine?
evaluate the patient in 8 weeks.
Okay.
And now, if we are in doubt, we delay 4 more weeks and we go to 12 weeks. And if you are in doubt, we delay 4 more weeks and we go to 16 weeks. But usually we are operating the patient in after neoadjuvant treatment in between 12 to 16 weeks. We're not, we are waiting at least 12 weeks to operate the patients. Okay. We are delaying the time to offer surgery more and more.
Why? What is the rationality of delaying so long? Because I mean, the usual recommendation is for 6 to 8 weeks. Why you delayed so long, 12 to 16?
Because it's proven that if you delay, and if you have a very good neoadjuvant treatment with good and modern equipment and radiotherapy, you are going to have more response, and you are going to have more shrink of the tumor, and probably you are going to preserve more sphincters. And this is why we choose our strategy to preserve more sphincters, delaying the time for surgery.
Professor Joel, is it your protocol as well?
No, I agree completely. And I don't know if you have the slide, because the slide explaining what Armando just said. I have it, but pass rapidly on it. But it is a paper of probably that Armando wanted to speak, and this is interesting paper, and it is exactly what we do also in France. Even in France, some surgeons don't do lateral lymphadenectomy. They prefer to continue eventually selective radiotherapy on the nodes if there is post-operatively a persistence of suspicion nodes.
Okay, how much time?
Do you have the slide?
Yeah, we have the slide. Yes, we have the slide.
You
But
see, you have exactly what said Armando.
Yeah,
and
yeah.
it is what we do.
Okay. So, how much time you live following your neoadjuvant RTCT? What's your time?
I agree. 6 weeks is minimum to wait to be sure. Because remember, when we do evaluation, even radiotherapy continue to be active on the eventual nodes. So a nodes limit 5 millimeter, perhaps 2-3 weeks later will be 3 millimeter or 2 millimeter.
Okay, okay. So that's what Armando is also doing. As he is living little longer time, he is able to preserve more sphincters. So, in fact, let us take up questions from the chat box. Frederick had asked a question: if in a narrow male pelvis, what about the down-up TME? I mean, he means transanal TME. That probably will be another session we'll be taking up. A separate.
No, I have seen fabulous surgical procedure done by QRA, a Japanese surgeon from Oncologic Center that is doing fabulous dissection by using a transrectal approach.
Okay, so what's your take on the splenic flexor mobilization? Do you not mobilize the splenic flexor in all the cases, or you have selective criteria that these cases I will mobilize, these will not? Armando, your view first.
Excuse me, Manash, what do you ask?
Splenic flexor mobilization.
Well, we used to do this at the beginning of the procedure.
Okay.
To splenic flexor mobilization, but when you are in a teaching hospital, it's very important to do this. But when you are in a private life in a private clinic, you can select the way when you are doing splenic flexor or not doing. And so acting in educational hospital, we teach to mobilize every case this splenic flexor. But when you are experienced enough, you understand that not every time you need to do that. And this is what we apply for private clinic.
Okay, there is another question pertaining to your Armando. You're living 12 to 16 weeks. Do you find a difference for those patients whom you are living 12 to 16 weeks and those whom you are operating 8 weeks? Do you find any difference in the dissection in the planes?
You know, the video that I showed you, they were performed 13 weeks after the chemoradiation therapy.
Okay.
And
okay.
I believe you saw no difference.
Absolutely no difference. We saw absolutely, as we see in 6 to 8 weeks, also the same picture what you showed us. That's great. Okay. So I think, is there any other question from the floor? If anybody wants to ask directly, please be visible. And
13.
Yeah.
You said 13.
13 to 16 weeks. Armando is living a time gap of
12 to 13. Yeah, 12 weeks, 12 to 13 weeks. I just want to answer one question related to Frederick. He asked me and Joel about probably transanal technique for very narrow pelvis. I would say that in the majority of the case, we are able to finish by laparoscopy or even using the robot. In very few cases, we are using transanal approach. But if you have to do an intersphincteric resection, Hudra, can you please mute? Yeah, thank you. If you have to do a intersphincteric resection, you can start transanally.
Okay, okay. Professor Joel, you were trying to make some comments?
No, I agree with, and happy to see that he's thinking as I'm thinking, Armando.
Okay, okay.
Now, I will show soon a movie to explain how important is as said, the cameraman, the assistant. And he said he's always working with the same assistant. And it's very important because if we want to do a soft dissection and safe balloon dissection, it's good to have assistants that follow you. And as I said, it's a mind-piloted assistant. He's helping you before you are doing. So he's moving the camera, moving the retractor, moving everything. So it's a movie I have called a mind-piloted video navigation and active retraction.
Okay, okay. Yes, anybody interested, please ask. You can ask directly also. If you have any questions, please raise your finger and be visible and ask directly also to Professor Joel Leroy or Armando.
Right.
Rudra, you are asking something? Rudra, you are muted probably.
When we are going to do para-aortic lymphadenectomy? Next step.
Never.
Never.
No, because if you have suspicion of positive nodes along the hyme with big nodes, you will never remove all the nodes along the aorta. If you do that, there is a high risk of plexus injuries. And the problem is it is a diffuse disease. And it is only chemotherapy that can control eventually. But para-aortic lymphadenectomy, I don't know the opinion of Armando, but we can do surgically. In gynecology, we do. We do, for example, for uterine cancer, we do a complete lymphadenectomy. But believe me, all the plexus are destroyed by gynecologists. And I have pictures showing a complete para-aortic lymphadenectomy. This is what they are doing. But for colorectal, it's not justified. For rectum, it's not justified.
Okay.
So in one of the centers where I worked in Japan, Tokyo Metropolitan, Dr. Matsumoto was there. So if he sees a large lymph node at the level of common iliac, then he has a classification of the pelvic lymph node into three parts. One is the lower part, level 1. Level 2 is near the common iliac. And level 3 is just the inferior para-aortic group, which is just above the iliac vessels, and it is autocaval and presacral nodes. So he used to do a kind of lower para-aortic node if he finds a big node at the level of common iliac, which is called as level 3 para-aortic lymphadenectomy in some cases, not in all cases. Definitely it is not in all cases, because in Japan the problem is they don't give pre-operative chemoradiation. They directly take up the surgery and they directly do the lymphadenectomy in almost all cases. They don't have any criteria for not doing lymphadenectomy. They do level 2 lymphadenectomy in all cases of CA rectum, even if it is T2 or T3. T3.
I think exactly Professor Joel Leroy also told the same thing. The entire concept of this pelvic lymphadenectomy came from Japan, where they probably do not believe on neoadjuvant RTCT. They believe more on lymphadenectomy than a RTCT. So from that only, yes.
We have to understand why we do lymphadenectomy. We do lymphadenectomy because we want to have a staging. The question is there a positive node? If there is a positive node, we will do adjuvant chemotherapy, eventually radiation. It's not to remove all the nodes, it's to remove enough nodes to find a positive node.
Correct.
To adapt our post-operative treatment. So if you have a positive node in the meso, if you have a positive, and if you have 10 positive nodes, this change nothing. You will remove a big node to avoid complication close to the aorta for eventually, or you will put clip around to do radiotherapy on.
Correct.
But the case you are describing, I don't remember having seen in my experience of 30 years. So I know that there is some difference. There is more lateral node positive in Asia than in West countries. There is more aggressive tumor in Asia. And I will say I have, it's not statistic, but when there is anterior tumor of the lower rectum, I have seen more lateral nodes. Why? Because when the tumor is posterior, lymphatic drainage is posterior in the meso. When it's anterior, it's more coming lateral. In my opinion, it is mechanical. But I cannot say when you have anterior where the limit. So remember, we do surgery to be minimal aggressive, and we wish to have a staging.
Thank
So
you.
do you mean to say that anterior tumor have more chances of a lateral pelvic lymphadenectomy than the posterior tumors?
I cannot conclude,
Exactly.
but what I have seen, it is mainly, so when I have anterior tumor, I'm more aggressive.
Okay.
Because anterior tumor, you have no meso anterior. You have a fascia or no fascia for the distal rectum.
Correct.
And drainage is around, not posterior.
So I think Professor Joel Leroy, you have highlighted on two very important things in carcinoma rectum. Your last talk on whether to preserve or sacrifice denonvillous fascia, and today's talk on lateral pelvic lymphadenectomy. Armando, you showed a fantastic video and the tricks of doing and maintaining the planes perfectly with your monopolar spatula. In fact, as Professor Joel, you also told that you do not believe on monopolar energy source. You believe more on sealing devices. You were using a Thunderbit, in fact, in your dissection. So
No. It was not what I say. I say to dissect plane, as I've shown Armando, and I remember I did a demonstration in Brazil, convince people using monopolar. I use more monopolar as a spatula or mini shears, curved scissors, but when we are dissecting around vessels, when I'm sealing lymphatic, it is important because we have to seal or clip the vessels.
Absolutely.
Lymphatic vessels.
For
dissecting plane, we have seen it's fantastic, and I tried to remember during the video.
Okay. So, what's your view on ligating or dividing the inferior mesenteric artery? I mean, that your concept of dividing after the origin of left colic, before the origin of the left colic?
No, I put clip because for teaching, we recommend to put clip.
Okay.
But when I'm not teaching, I'm sealing.
Okay. But where you seal? It is before the origin of left colic or after the origin of left colic?
The left colic?
I mean, you are closer to aorta or you are away from the aorta? It doesn't make any difference.
We do skeletonization, as you have seen in my movie, of the origin of the aorta, and we clip at 1-2 centimeter distance of the aorta. Okay.
Armando, what's your view on this?
It's the same of Professor Joel. It's the same. Exactly the same.
Fine. So, any other questions from the floor? Anybody wants to ask some questions?
Hello.
Yes.
Yeah, I had put up this question.
Yes.
Regarding
differentiating nerves from the connective tissue.
Please.
In fact, Professor Joel, Dr. Doshi wants to how you differentiate connective tissue from nerves. I think that's probably much easier. The connective tissue, if you just give a stress, they do not remain taut as you find the autonomic nerves. They become very taut and make things very prominent. That you do not and should not have any confusion in differentiating nerves with the connective tissue, particularly in laparoscopic surgery, because every fiber is so nicely visible and you can make them taut. Professor Joel, you differ on this view?
What is your?
His question is how you differentiate the connective tissue from the autonomic nerves.
This is a technique of dissection. You have seen I'm not using a monopolar dissection in all the plane between propria fascia and sideward fascia. I'm dissecting, I'm brushing the tissue to find the branches of the nerve, and I find always.
No, but his question is how you differentiate, because both of them, they look alike. So I just told that if you give a stretch, connective tissues, they will never remain as taut as you find the nerves, whether the lateral pelvic nerve or the autonomic plexus. They surely behave little different than the connective tissue. So do you have anything else to say on this?
I will do advertising. You can watch the movie I just put on recently. I put recently on YouTube, on my channel YouTube, where I show the nerve. But we can have eventually a webinar concerning nerve preservation during surgery. Yeah, it would be interesting too.
Okay.
But how I do it, I
think somebody had asked,
as Armando have shown, the traction, counter traction. If you have no preoperative radiochemotherapy, you will have a pneumodissection, and you will open the plane, and you will have the possibility to find the anatomical structures. So this is playing with traction, counter-traction.
Okay, I think Dr. Thakur had asked regarding this tying of inferior mesenteric artery at its root, but that has already been discussed. It's 1 to 2 centimeter from the origin. It's all ligated. Anyway, I don't find any further questions from the floor. And is anybody else interested to ask something, or we'll just go on winding up this session? I think thank you very much, Professor Joel Leroy and Professor Armando Melani for joining today. It was a great session with both of you. Armando, I really appreciate that in spite of recovering from COVID, you have spent nearly 2 hours with us. Great. With your enthusiasm, we really appreciate. We thank from the core of our heart, Professor Joel and Professor Armando. We really appreciate your joining this session and sharing your wisdom with everybody and clearing out many of the concepts. Thank you very much, and we'll be happy to have you in upcoming some other session as well. So if you have any concluding remarks to give, you are most welcome, Professor Joel Leroy or Professor Armando, if you have anything to say as a concluding remark.
So, Manash, thank you very much for this great opportunity.
Thank you very much. Thanks, and I wish
Joel, thank you.
Complete recovery. And we wish that tomorrow, I'm happy that tomorrow you are coming back to your theater from a 15 days gap. That's good. I'm happy be back to the work, and wish that you be absolutely in the full vigor and full force coming the next time that we meet. So thank you very much,
Thank
Professor.
you. Thank you very much.
Thank
It was
you.
a privilege for me
And thank you, everybody.
Joel and you.
Yeah, thank you. It's a great session. Thank you very much. We really appreciate.
Bye.
And thank you each and every one of our friends joining this evening and spending time with us. Next week, same time, we'll be meeting from another session on carcinoma gallbladder. Thank you very much. Thank you very much.
Thank you too.
Thank you. Thank you.